Aspirin, or acetylsalicylic acid, belongs to the class of drugs known as NSAIDs. In our previous video on aspirin, you were introduced to aspirin, its mechanism of action, and its toxicity. So, if you remember from that, the symptoms of salicylate poisoning or salicylism, it includes tinnitus, nausea, vomiting, hyperventilation, and sweating. While acid-based disturbances are complicated, because aspirin not only stimulates the respiratory center, causing a respiratory alkalosis, but also uncouples oxidative phosphorylation, which may cause a metabolic acidosis. Coma is usually uncommon, but if present, indicates very severe poisoning. While immediate management of salicylate poisoning includes measurement of plasma salicylate concentration at 4 to 6 hours post-ingestion, electrolytes and blood gases. Gastric lavage up to 1 hour after ingestion is followed by activated charcoal administration. For moderate intoxications, intravenous sodium bicarbonate is given to alkalinize the urine and promote salicylate excretion by trapping the salicylate in its ionized polar form. For severe poisoning, for example, patients with severe acidosis and serum salicylate level more than 90 to 100 mg per deciliter, emergency hemodialysis is performed to remove the salicylate more quickly and restore acid-base balance and fluid status. Now, coming to acetaminophen, or you may know it by its other name, paracetamol. It is a commonly used analgesic. We already have a full lecture on the pharmacology of acetaminophen. Do check that out if you want to get in-depth knowledge. But right now, we will only be focusing on the toxic effects related to this drug. A fatal dose of paracetamol may cause hepatocellular necrosis. This dose is equal to more than 10 grams, almost 20 to 30 tablets. Well, clinically, the acetaminophen poisoning is categorized into 4 phases. Phase 1 appears within 24 hours of poisoning, where patient will have anorexia, nausea, vomiting, and diaphoresis. While Phase 2 appears after 24 to 48 hours of poisoning, and general signs at this stage include right upper quadrant pain, increase in liver transaminases, increase in bilirubin levels, and a prolonged prothrombin time. Now, if we move forward to Phase 3 poisoning, it appears after 72 to 96 hours. Signs include peak hepatotoxicity, jaundice, coagulopathies, and patient may have signs of hepatic encephalopathy as well. Now, the last phase, that is Phase 4, appears 7 to 8 days after poisoning. At this stage, either the patient has recovered or death happened. Well, normally, paracetamol is metabolized, mainly by conjugation reactions in the liver, but high doses saturate these pathways. This forces paracetamol down an alternate pathway. The first stage of this alternative pathway is performed by cytochrome P450 enzyme. The drug is then oxidized to a reactive quinone intermediate, which is a hepatotoxic compound called N-acetyl benzoquinonamine, or NAPQI. Under normal circumstances, the NAPQI is quickly cleared from the liver by conjugation with glutathione. After about 10 hours, the liver supply of glutathione gets exhausted and NAPQI accumulates and damages the cells. It does so by covalently binding to thiol groups on the cell proteins and kills the cell. So, keeping this mechanism in mind, there are certain patients that are at increased risk of toxicity by acetaminophen. Drugs that induce enzyme P450, such as antiepileptics and chronic alcohol consumption, will increase the rate of formation of NAPQI. Patients with low hepatic glutathione stores, such as those with HIV, anorexia, or cystic fibrosis, may also be at increased risk of hepatotoxicity. But not to worry, potentially life-saving antidotes, in the case of paracetamol poisoning, have also been discovered. Intravenous N-acetylcysteine prevents hepatic damage from NAPGI, increase the synthesis of liver glutathione. An oral alternative is methionine that is given over several days. Well, the most effective antidote is acetylcysteine, given intravenously within 8 hours of paracetamol ingestion. Patients who have taken an overdose of paracetamol should have a blood sample taken at 4 hours or later after ingestion to quickly determine the plasma concentration of drug so that the antidote can be given. If less than 1 hour has elapsed since ingestion, a dose of activated charcoal should be given. The decision on whether to continue treatment with the antidote is decided by referring to the plasma paracetamol concentration. We also have to keep in mind the high-risk patients too, like patients taking enzyme-inducing drugs and those with glutathione depletion. Now, if the time since ingestion is less than 4 hours, the plasma concentration is unreliable because paracetamol absorption will be continuing. Adverse effects, including anaphylactoid reactions, occur in about 5% of patients. The prothrombin time, or PT, is the single best indicator of hepatic function. Patients whose PT is rising 24 hours after ingestion should continue N-acetylcysteine. A PT level more than 36 seconds at 36 hours suggests serious damage. Hepatic and renal function is monitored using prothrombin time, or PT, liver function test, or LFT, and urea, and electrolytes, or U and E's. So that was about aspirin toxicity and paracetamol toxicity. Next, we'll be discussing opioids and tricyclic antidepressants toxicity. So stick around.